So I want to talk about complex aneurysms. This patient has of the aortic aneurysm repaired 13 years ago, and the peripheral aorta is growing from 4 centimeter to more than 5 centimeters. Also, this patient has a thoracic aneurysm from 4 centimeters to 4.5 centimeters, and these patients are referred to us to the treatment. So this patient has aortic iliac reconstructions before, as I mentioned. So there was a thoracic aneurysm and separate the peripheral aorta aneurysms and triple repairs. So this is a thoracic aortogram shows there has aneurysm change here. So this patient need the cover this lesion for the T-branch treatment, and they also peripheral aorta. So in the Western world, there are many stent grafts for the treatment of peripheral aorta. So far, we have maybe the last country to be introduced new technologies. And I think that the fenestration, as I mentioned, it's good for the ejecta renal replace. And we recently, 3 years ago, we have a T-branch device for thoracoabdominal aneurysms. The ceiling zone is quite high to compare to the fenestration device. And this is the indications of this device. And this is off-shelf the device. And there is an indication for the visceral anatomies and for the indispensable anatomies, and aortic diameters need to be above 25 millimeters, and celiac SMA around 6 to 10 millimeter in diameter, and renal 4.8 millimeter in diameters. So these patients was within the IFU, so we decided use T-branch device. So we access with the percutaneous from the both groins with the pre-closing techniques, and access from the left axillary arteries from cut-down techniques. So after completion of both access, we check the CT navigation to define the orifice of each branches. And at this time, we don't have a full spectrum of a distal body, so we need to cut off one of a proximal segment to adapt the distal landing zones. So before doing, we remove the proximal segment and reload it to the chest. This is how we did in the back tables. It's a little long. So, and then we put the Janus alpha is a 28 to 38, 34 long segment Janus stent graft for the proximal fixations here. And then we deploy the T-branch off-shelf the device afterwards. So when we position the T-branch device, we need to see the marker. Oh, sorry. This presentation quite complex, sorry. So this is a proximal Janus alpha, And then we positions T branch, and the most important thing is here, the orientation of a T branch. So we can see anterior markers and proximal anterior marker and distal anterior markers. So this rotation is very important, and this is celiac and SMA markers, and this is both right and renal markers. And we check the orientations, and when we've confirmed the right orientation of this stent graft, we deploy the T branch stent graft. So there is a tendency of kinking of a stent graft during the deployment. So doctor need to rotate like this to check each marker's orientation in the right positions. So many people's help for the T branch case. This was our first case. So we check, oops, sorry. We check each locations with the pre-designated markers here, and we can see this is a celiac arteries marker. This is SMA's marker. This is right and left inner markers. And these are target vessels and need to be less than 5 centimeters in total length for long-term durabilities. And then we deploy the distal part without problems. And then we switch to the brachial, proximal brachial or axillary approach. And then we cannulate the left renal, right renal, and SMA and celiac branches like this. And this T branch is not preload device, so we need to select each branches during the procedures. And it is, I think, a more difficult portions compared to the 10B procedures. So we check these markers and our ring markers to select each branches. We put the 12 French ancel sheaths from the proximal descending thoracic aorta, and we put another 8 French ancel into the 12 French ancel sheaths to select each branches. This was we use Bentley stent graft for each lesions, and this is a 6 by 8 millimeters Bentley, and we use 10 to 8 millimeter, 10 to 6 millimeters Bentley graft for the celiac and SMA lesions. So this is almost the final celiac. And then we do completion angio for this. Oops. What is this? It's almost finished. Yeah, there was a quite good result. For the completion angio, there was some sluggish endolex, but we don't know which is coming from. And during the follow-up, we found that this is endolex from the IMA origin, so it was a type 2 endolex. And this was done 2 years ago, and the patient is still stable. Thank you for listening.